I actually think it's interesting. In preparing for this session, even talking about healthcare reform is like a giant, mythical giant squid. Just to understand where do you engage the topic, there are so many angles to it and so many details. And it affects our economy, it affects our lives, it affects our health. And so it's such a challenging topic. What I thought, we have an amazing panel arrayed today. So I thought the approach for today, for two things I want to establish. One is that I'd like it to be that we have a panel of experts here who happen to represent different perspectives and different constituencies, but everyone on this panel has actually been deeply involved in the healthcare reform debate on many levels. So I'd like it to be an open, free-flowing conversation. And my second goal for it is that I think because of where we're poised on health reform, I want this to be very much a conversation. So the format for today is I'll introduce all the panelists, and then I'll start with a series of questions to, in lieu of opening statements, I'm going to throw out a few questions to individual panelists to kind of get the conversation started, and then really spend most of the time, give most of the time to the audience to ask them questions and really engage in a dialogue. So hopefully that works. The one piece of setup I'll do, just in case anyone's been on Mars for the last 4 months and hasn't been following the health reform debate, effectively, as Senator Daschle eloquently put it yesterday, it is about coverage, cost, quality, and prevention. Everybody in Congress, everybody in America, Republican, Democrat, old, young, agrees that those are the issues, and I think we agree with Dr. Chopra that you need to solve them simultaneously. It's a very complex, simultaneous equation. The other update is that where we are poised in Congress, I think this conversation comes at a very, very good time. We've got enough to chew on, and we have enough of the framework where I think all of our panelists can give you their candid opinions. They've seen at least the outline in the House. We have a House bill, a draft House bill, and we have something from the Health Committee, not the full-fledged Finance Committee, but we're beginning to see smoke signals and get a sense of what they're working on. So I think within the debate, we're poised at an excellent time where we have enough information where the stakeholders can kind of share with you their thoughts, and we have a clear sense, but there's none of the decisions. Unless someone will disagree with me, I don't think any decision is locked down, other than we want to try to cover all Americans, we want to control costs, and we want to have high-quality health care. Hopefully we lock those down. So with that very, very brief high-level introduction, hopefully no one on the panel disagrees with those universal platitudinal statements. I will turn it over to the experts here. Let me just introduce them, and then I'll start with some questions. To my left here, we have Mark Ganz, who's the CEO of Regents, Regents Health Plan, a nonprofit health plan serving 3 million members in 4 states in the Northwest. And Mark is also the co-chair of the Aspen Stewardship Group. So he's been spending a lot of time thinking about what stewardship means in the context of health reform. So he brings a lot of unique perspectives and very interesting perspectives in terms of both as a health plan executive, but also prevention, changing the culture of healthcare. I think you'll really appreciate Mark's diverse views and his perspective. Randy DeFrahn is the national director, make sure I read this correctly, of the executive director of the National Coordinating Committee for Multi-Employer Health Plans, which covers 26 million members that have been bargained through negotiations, a lot of small employers, and he'll talk about what a multi-employer benefit plan. I'm going to ask him to explain that, because I think it's actually a very important piece of health reform. And Randy has been, you'll hear from his remarks, very involved in the negotiations around financing, because they affect very much his membership, around coverage, around the structure of a public plan, the health insurance exchange, and deeply involved in those discussions. Next is Laurie Rubiner, who's the Vice President of Public Policy for Planned Parenthood of America. And she has also 20 years of experience in health policy for both Republicans and Democrats, so knows this issue very, very well. So her current hat is looking at kind of reproductive health and those issues, but has also worked previously for Senators Clinton and Chafee on health policy, so brings kind of wealth of experience. The next gentleman is Dr. Don Berwick, the president of the Institute for Healthcare Improvement. In the bio in your book, it says one of the leading experts on health quality. I think that's probably a little modest. I say he's the leading expert on healthcare quality. And so I think he's been front and center on all of the discussions. We heard a little bit from Dr. Nobel yesterday about cost effectiveness, comparative effectiveness, but also all of the elements of quality, which I think everyone realizes that this just cannot be a financing bill. It's not just about subsidies for health insurance. It really has to be around changing the way we deliver medicine and the way we pay for how we deliver medicine. So Dr. Berwick has been at the center of that discussion. And finally, we have Dr. John Seffrin, who's the CEO of the American Cancer Society and the Cancer Action Network, who is beyond just being a champion for cancer and transforming that organization, has really been a champion for prevention and integrated thinking of the way we address healthcare in the country, from tobacco control to clinical preventive services. And also, I think we'll hear later from him about really been a key force in mobilizing the ground troops in terms of advocacy for health reform and support of healthcare reform. So with that, I think you've got a good sense. We've got a good panel, a very, very good panel. So let me start with the first question in a sense, and maybe actually Randy can take a first cut at this one on the coverage issue. I think there's general agreement we want to cover more people. But the how of covering people, the pay or play, the individual mandate, the health exchange, I think there's a lot of devil in the detail and how that plays out. So if Randy could take a first cut and then others jump in around not the goal of coverage of all Americans, but the how we cover them and why it makes a big difference.
Sure, I'll take a stab at it. I think first of all, just so you understand where I'm coming from, it'd be useful to tell you about the kinds of plans that I represent. There are about 3,000 collectively bargained health benefit programs out there. They cover 26 million active and retired employees and their families. And they're really across the entire spectrum of the economy. A lot of people think of multi-employer plans as union plans. Since 1947, that hasn't been the case. They're jointly managed. They have to have equal representation from labor and management. But they're in the construction industry, the trucking industry, aerospace, mining, entertainment, building services, maritime, healthcare, hospitality, food production and distribution, retail, textiles, communications, steel, paper. You get the message. It's across everything. They are, by and large, self-administered plans, and probably 60 to 70% are self-funded. They have only one source of income. That source of income is the contributions that come as a result of a collective bargaining agreement. There is an agreement that X dollars per hour, or in the trucking industry per week or per month. There's some other variations on that for entertainment, but for the most part, it's an hourly contribution rate that goes into these plans. And then there's a board of trustees, fiduciaries who are charged with having as their sole and exclusive obligation the interest of the plan participants. And there have been Supreme Court cases that go to the heart of the fact that these plans can't, that the trustees can't represent the interest of the parties who appoint them. So it truly is a model that is a little bit different. Now, the one thing I think that most people have, even people who are vaguely familiar with our plans, the one point that they don't quite understand is that this is a model that covers small employers, small businesses. About 90% of the 60,000 plus employers that contribute to these plans have fewer than 20 employees, and over half have fewer than 10. So when we start talking about discussions about who should be in this, who should be making contributions, and how it should work, then I think that it's an entirely different perspective from these small employers who for years have carried the burden of cost shifts from their competitors who don't provide employee benefits through uncompensated care, and certainly some of the cost shift from the public programs that don't pay their fair share as well. Talking about the exchange and whether there's a public program or not, we have a couple of positions on that. First of all, if there's going to be a public program, then I think it really does have to, as one of the other speakers said yesterday, it has to reflect the fact that it should be a level playing field. If it's going to be an option, then they shouldn't be able to start out with a fee structure that undercuts the rest of the market, because in fact those fees would be transferred back to the private sector. If you were, I'll deal with the public option first, and then talk about pay or play. There have been some discussions with some of the committees about opting in and opting out of that public plan, and because of the structure of our plans in particular, we focused on this. The contributions come in on an hourly basis, but you don't become immediately eligible. Generally, there's an advanced eligibility period, perhaps 200 hours, to establish eligibility. Now, that's essential, and I'll use the construction industry as an example. The construction industry operates by way of an implicit contract between labor and management. labor supplies ready, trained labor to companies that need it. And in order to do that, you have to have people who aren't working, who can be sent out to the jobs. So there is an understood period of unemployment that has to be covered for those employees. So that while there's a lead time on getting your eligibility established, there's also a long trail. Typically, the quarter following the quarter in which you last worked, you would be eligible for that entire quarter. And some have even longer trail periods. However, given the kind of economy that we have right now, it's likely that a lot of people are going to be unemployed for longer periods than that. As a matter of fact, the construction industry is seeing, I've seen estimates anywhere from 23 to 30% of the construction industry is now unemployed. So it's likely that many of these people, particularly the newer people coming into the plans, who are just finishing their apprenticeships, that would perhaps not be employed for some period of time. Their eligibility could run out, and they, at that point, could be eligible to opt in to the public program under the way that it was originally designed. That's fine. There are subsidies built in for people who have low income, and they should be able to access those. The problem comes at the other end, when, in fact, the original design on this was that once you were in that public program, you didn't have to come back to your employer-sponsored plan if you didn't want to. Remember what I said. These are obligations that arise out of a collective bargaining agreement. So when you start to work again, those hourly contributions come from your employer into the trust fund. If you opt not to come back to the trust fund, and there's a requirement that the employers have to pay anything into the public program, it could be that the public employer has to pay, or the employer has to pay twice into the trust fund as a result of their bargaining agreement, and into the public option as another source of revenue for that. One other problem with this is that these are natural pooled risk plans. There's no selection, no medical underwriting, no age adjustments. They're funded on what in the insurance jargon would be considered to be single premium amounts. Everybody pays the same flat rate, whether you have dependent coverage or not. If you take out people at the bottom and allow this option to be exercised, which, by the way, under federal labor law is illegal because the unions have the exclusive right of representation, then that destroys the natural risk pool as well. So there are a number of concerns here that we've expressed, and I believe that we've made some headway with that. The last piece that I'd like to make on this public option is there's been some concern that if it's open to employers to opt into, that large employers wouldn't be allowed to get in, and nor would our plans be able to opt in as a group, which seems to undercut the idea of increasing the size of that pool, and contributes to the notion that there may be some adverse selection engaged there. So with that, I've taken up more time than I think I should have, but I thought it would be useful to get the background out there.
Sure, and let me then turn to the other panelists on the coverage before we walk away from the coverage issue. And particularly, I'd love to hear from John and maybe Don, actually all of you or any of you. What are your bottom lines in terms of coverage? I mean, Jim Mongan, who's at Partners Health and who's been around health policy for a while, talks about the slippery slope that we sometimes face in Congress, where you start at 100%, then you get to 98%, and then you're at 96%, and now you're at 94%, and then you begin to lose the value of why you did universal coverage, which is A, to get people better access, but then also all the insurance reforms and things. So it'd be interesting to hear from others, is there a bottom line in terms of what our goals should be or where we should be moving with the coverage debate, in addition to these comments from Randy?
I think if I would just say, I think our goal should be 100%, and we should stick with it over time.
I agree with that completely.
I mean, it's going to be difficult to get there, and there will be people, even in a mandated environment, that will decide not to be covered. And the real question will be, how do we as a society believe that we should be enforcing that in any sort of heavy-handed way to try to get them in if they don't want to be in? There's a lot of different ways you can go at that. You can encourage, or you can really penalize. And I don't think that our society has a stomach for a really strong penalty for people who decide to stay out, which means that there will be those who stay out. Nonetheless, I do think the issue of education is much more important, and because it gets at the cultural issues that we have that really, to me, are the problems in healthcare. or the root of the problems in our healthcare system. And we need a lot more focus on how we educate people as to why it is of value to them to be covered. And I'd rather see a lot more dollars going there than into penalties.
Thanks. John, do you want to take a crack at the coverage issue, or no, since you talked yesterday about access being such a central point?
Absolutely, and I think very significant to hear Mark say that. So the first person to speak comes from the commercial sector, saying it should be 100% and spontaneous applause. I agree with that. I think that we had a high-level meeting with our people a few months ago, and I said, I don't want to hear any more of this, what if something happens? I said, we have to work as though something is going to happen, and we want to make it, something big's going to happen, and we want to make it big good, not big bad. And so this is as difficult as it obviously is, and who knows what will actually happen. I think we have to own up to the fact that this is the best opportunity we've had in a half century to get it right. Mm-hmm. And all of our experience, plus data, show quite clearly that anything less than 100%, you don't get the kinds of returns that you want to get socially, medically, health-wise, and economically.
So the sense is hold the line. I mean, I think even Randy, you would say from your remarks, holding the line on universality is a linchpin to kind of making this work, and probably Don and Laurie would agree that the universality is just a linchpin. Without that, then a lot of other things begin to fall away.
Absolutely.
I mean, that's the sense of it. Let me turn to cost and quality, and I'm going to read a hot-off-the-press research finding that I picked up at a table outside of the last session. Americans think lower cost and improved quality are possible. 77%. This is from Research America. In a recent survey, 77% of Americans said they are dissatisfied with the cost of healthcare in the country. As U.S. considers health reform, do you think costs can be lowered while improving the quality of care or not? 76% said yes. So let's talk a little bit. I think cost containment has been an issue that's been talked a lot about in Congress, and now we're hearing some of the Democrats, the Blue Dog Democrats, are saying there's not enough cost containment for us in this bill to really be supportive. Don, if you want to kick us off in that interface between quality and cost containment, then maybe Mark and others can jump in.
Sure. Well, it pivots off the first point. I mean, I view universal coverage as a moral issue. It's an issue of justice. I don't want to live in a country where you can be sick and not get care covered. So it's a starting place. So when Senator Daschle says coverage, cost, quality, and prevention, I'm completely with him. I'm going to try not to get wonky, and I will be brief, but the most important technical thing to realize is that coverage, cost, quality, prevention are not causes, they're effects. They're outputs of a system of production. A systems view is key to me in analyzing the current debate. By a systems view, I mean a sense that performance is a property of the system. So I have a car, it's 20 years old. If I take it out on the Bonneville Salt Flats and floor the accelerator, it'll have a top speed. I don't know what the top speed is. My children probably know, but maybe it's a 92. You understand how the top speed is a property of a car. That's true of every system. It has a capability. So I could yell at my car. I could create a new incentive package or pass legislation about it. It doesn't change its speed. It's top speed. Another way to think about it is in Africa there's a saying, weighing a pig doesn't make a pig fatter. Just having the intention isn't enough. So you have to understand, well, what system produces the top speed? In our case, coverage, cost, quality, prevention. From a systems view, the current design of the American healthcare system is incapable. It cannot do what we need it to do. So we have a choice. We cannot do what we need to do, which is have justice and affordability, or we can have a new system, one that can. That's what we're all facing. We have to admit the current design is incapable. Mm-hmm. If the political process is one in which we sum up the needs of all the stakeholders, we end up with the current system, which is illogically, it's an illogical solution to the problem of capability. The good news is we know it's not like curing HIV. We don't know how to do that. We do know how to have health care that works. 3 ways we know. One is Europe knows. We have systems outside the country. We refuse to look at them. We refuse to take them seriously. We say it's not American. We can't do that. We call it impossible because we decide it's impossible. Mm-hmm. I don't know how to get that into the political debate, and I've practically given up on it right now. But you can have care at about half our cost with every bit of performance and probably better than we currently have, because it exists. You can't tell me there isn't such thing as an airplane, because I can see an airplane. We just don't want to do it that way. Well, that's a choice. That's a social choice, and I don't run Congress. The second is we have some in the U.S. We have very high-performing systems. The classical HMOs, which are widely touted, are very, very good. You'd be very lucky to be in most of those integrated systems today, compared if you want to meet the social need. General Sutton's here. I'd say the Military Health Command, if you want to see some fabulous care, go watch them. They can do things the other systems can't do because they're so organized in the way they approach it, and they do it at a reasonably affordable price. The Veterans Administration and so on. So we have them. Atul Gawande and Elliot Fisher and Mark McClellan and I had a meeting Tuesday in Washington. We invited 10 communities from around the country that are low-cost, high-quality communities. I think they are. I'm not sure about all of them because there's some cost-shifting issues. But they're doing it. They're 70% of the cost of the American median. By every quality metric we have, they're better. They know how to do it. So to me, the analysis of the affordability issue and the traction around the bills on the table are, do they have the edge to cause the change in the design of the care delivery systems that we now want to afford and extend to everybody? We'll dig into that, I guess, in this panel. Right now, they're getting there. There's some good things in those bills, but they don't quite get over the hump of forcing the change in delivery that we need. I think it's a commons problem, as you said, Laurie, in your comment yesterday. If everyone just tries to keep what they have, we don't have a new system. How do you get in a democracy a commons problem solved? And I can't figure that one out. So that's more than you wanted, Peter. That's how I think.
So the only thing I would add, and it is really intended to be additive, there are sectors within our healthcare system that actually are very efficient. Take alternative care therapies, for example. Surprisingly efficient in terms of price stability over time and very high customer satisfaction. If you even just compare over-the-counter pharmaceuticals versus prescribed pharmaceuticals and the business model for those two different ways of receiving a medical intervention, if you will, the one is a much more economically sustainable model than the other. So there is truth in what you say, Don, that there are models outside the country, but there are models right here that I'm surprised, frankly, at how incentives to unleash innovation in a different direction than where it goes today. And there is an incredible opportunity there that we're still pitching for and hoping, that the bill will actually create that kind of an economic incentive to unleash innovation in a different direction. I think we would all like to see that. We're doing some stuff as a company on an individual basis with delivery systems, and it's pretty interesting to see how when you change the incentives and you reward different kinds of behavior than what the conventional approach is, people change, and the experience of the patient changes.
So I have a question for the group, actually, for the whole panel. Given that perspective, is this a CBO problem? They seem to be the central force now that we've set up the parameters such that we want to cover everyone, we want to do all of these things, but we need it to be budget neutral or deficit neutral. That puts CBO squarely in the driver's seat as if they weren't before. Or is it a political will problem? Is this really the politicians need to step forward and it's not a scoring issue? It's actually truly getting the votes and developing the political will to do this. I mean, is CBO's scoring system, does it block transformation, or does it hold us in check for magical thinking in Congress, or some of both?
So I think it's a little bit of both, but I do think that we have to have an honest conversation with people, and we still really haven't done that. So when the president was asked in his press conference the other night, are people going to have to give something up? And he sort of said, not really. That's not really an honest answer. And until we get honest with people about the fact that maybe you don't talk about it. I mean, in 93 it came down to sort of winners and losers. And I don't think you have to talk about it in those terms, but I think people do have to we have to have an honest discussion about how much health care we really need. And I think Don could probably help us understand that better. But we have to have an honest dialogue about how much health care we really need, and what people actually are going to have to not have in our healthcare system and what they don't need. And until we're really able to do that, I don't think we're really going to be able to move it forward, because we're not really being honest with people about what it's going to take to move the system to whatever system it is, whether it's the European system or whatever it is, that's going to move us to, because we all know we all can look dispassionately at all the different systems that are out there that work, that have quality, affordable care, and we all know the numbers, that we spend more than any other industrialized nation, and we have lower outcomes, and we all know that. But until we're willing to actually say, okay, we're going to do what we know needs to be done and take those steps to fix it, we're never really going to be able to do that. And that's some of it's political will, but some of it's just honesty amongst ourselves, and I think we always knew that. And then I think some of it's political, and some of it I think is CBO. We had an interesting conversation this morning about we all tried to get CBO, we'd like them in a perfect world to say that some of these preventive measures, quitting smoking, having better cardiovascular measures would score savings, and CBO won't do it. And Don can explain. I asked Don this morning because it's so frustrating, because it seems to make sense intuitively. If you get people to quit smoking and you have good anti-smoking procedures in place, or you have better cardiovascular measures in place, it seems intuitive that costs would go down, right? Because people would be healthier. And so why doesn't CBO score that? Why doesn't it give us savings? And so Don explained to me that it's not really CBO's job to do that. Because that's 20 years down the line, and there's no documentation that it actually saves money. So it's because we sort of don't want to it's not up to our government entities to put a value like that into, it's almost like they don't want to say, we value these certain behaviors. That's not their job. We need another entity other than CBO to say, these are the kinds of behaviors that we value, and we want to encourage you to do them. But that's not CBO's job, so we need another entity to do that. And I think Don could speak more eloquently about it.
I won't be eloquent, but I want to explain what I mean. I'm happy to have CBO. I think CBO tells the truth. They tell us what something's going to cost. That doesn't tell us what to do. It tells us what it's going to cost. And there's so much hand-waving and so much advocacy. We need somewhat dispassionate, very technically skilled people to say what something's going to cost. Then we get to decide, do we want to buy it or not? If Congress chooses to give the CBO the right to decide what Congress does, because they'll only do things that save money, well, that's a social choice. When I decide to go to a movie, I don't do it because it saves me money. I just say because I want to see the movie. So if we want smoking cessation and better care for women, we have to decide sometimes if we want to invest in it. The only part of what you said, Laurie, that I would add to is we can have everything we want at a lower cost than we have today, everything that really helps us. We're being tricked as a society into buying things that don't help us. And that is a very, very pervasive problem in American society. We don't have to convince people that something will be taken away if we want to rationalize care. It doesn't have to be, I'm sure of it. But we have the people that sell what we don't need have captivated the vocabulary, the language, rationing. We heard this attack on NICE, which is the British agency that looks at costs and benefits of treatments. It's a brilliant agency. It does an amazing job. It informs public discourse in a way we can in America. So I would wish we could overcome the feeling that this has got to be a takeaway. There's a third way, change care.
Is David Kessler here? We can get his next book. It can be the healthcare industry. He's in the food and tobacco, and now maybe we can have him look at the healthcare industry, having to sell things that we don't actually need. It's quite persuasive in his arguments about the food industry and tobacco. Let's shift gears a little bit and talk about specific populations. And I'll start with Dr. Seffrin and talk about, from his perspective, persons with cancer and vulnerable populations, a little bit broader than cancer itself. How do you see the reform bill shaping up in terms of their issues, access, quality, cost? Are you liking what you're seeing coming out of the committees? Is it overall promising? Are there things you'd like to see from the perspective of a person who really thinks about people with actual healthcare needs?
Well, we think progress is being made. Clearly we're not where we need to get just yet. But let me tell you a little story very quickly, which is 4 years ago, I went to our Board of Trustees and said, here's what we've discovered, but I'm not going to go there without you. But the American Cancer Society can't fix the healthcare system, but we are the largest voluntary health organization in the world. And you know what? We have good data and lots of experience that people care about cancer. And I've not, to this day, ever met someone who could look me in the eye and say, well, they've got cancer, but they don't deserve to be treated. It just doesn't want. So we have a call center that answers calls 24 hours a day, 7 days a week. One of the only not-for-profits that has that facility. And we noticed, and we answered 1.2 million calls last year, and we noticed a growing number of calls of people saying, I've got health insurance and I've got cancer, but I can't get the treatment I need. So we developed a whole line of business, and we now have a health insurance assistance service. We're able to help 1 in 6 people that calls. 1 in 6. And actually when we started it was 1 in 5. So it's getting worse. And what we have going for us is 500,000 cancer survivors who are full-time volunteers for us. And so we've begun training them and just letting them tell their story. And we put it on the media. We've taken them to Washington. But the conversation changes because then it forces the notion of you see, we're in all 435 congressional districts. We have trained volunteers and paid staff in all 435 congressional districts. And when you go explain it that way, and you're one of my constituents, and I can't get the care I need, that helps balance this issue about the cost. So relative to CBO, I think we have to live with them. I think it's a terribly important metric. We need to know what something's going to cost, but that's not all of cost. That's just certain kinds of costs. And then there are other kinds of costs. Bottom line is that our experience and our analyses, incomplete though they may be, tell us, and we've then said, we will focus most on the concept of prevention and quality of life throughout life. And if we have a mature adult conversation about the true value of prevention, and about making sure people get state-of-the-art care, particularly at the end of life, we can make this work. But remember, as the Robert Wood Johnson data has told us for years, quality of life at the end of life isn't necessarily in intensive care.
Right. And the amount of money that is spent in the final 30 days of a person's life is just tremendous. That we talked about this on a panel yesterday, but the inability of the healthcare system to know when to move people from curative treatment to palliative care and do that with grace and work with the families well is a huge problem. This is another one of those surgical strikes that within a bill could really change the culture in healthcare, and that would be would render hugely more patient-centered approach. To me, the issue, I certainly understand John's focus on people needing access to cancer treatment, and I think that is a given. But what we also have to do is work it on the other side, which is understand that the kind of care that cancer patients get is also helpful to them and in their stage of life. I've seen it personally with my family where people get taken for a ride, honestly. Cancer patients taken for a ride, and with way too much intervention and treatment, which is not positive for them in their quality of life. So I think I keep coming back to what's going on in D.C., and this is going to be an overstatement a bit, but it captures it for me, is not really reform. There's pieces of it that could, in fact, cause reform, but it isn't. If you go back, the Aspen Institute Health Stewardship Project, one of the things that is a central tenet is that simply trying to answer the question of access is not reform. It isn't enough. It is important. But in the 10 principles we put forward, and the little blue book that you got in your packet, and I highly recommend to you, those 10 principles really talk about all aspects that have to be dealt with if you're dealing with reform at a human level. And thank you. here, and that if we do, and that is not a prescription, by the way. It's not a healthcare reform prescription. It is simply outlining principles that need to be addressed, and we are agnostic in this purposely as to what the answer is. We're simply saying there needs to be some addressing of the things in these principles. And if you look at the bills as they exist today, they fall far short of these 10 principles. They deal with about 2 somewhat effectively. That's the opportunity between now and October or November, is to see if we can get something that is more holistic than what we have.
You know, I'd like to add one other perspective here. You know, we're operating now at, I think there was a comment made by one of the congressmen the other day that we need to be operating with our foot to the the pedal to the metal. And one of the other ones said, but do we know where we're going? And that's really the point here. I think we have to meet some simple objectives. And the noise that we've gone through over the past few years makes it very difficult to accomplish this within a short period of time, because we've got to get rid of all of these different conceptions of what care is and how it should be provided. That, yes, if you like your care, you can keep it. Well, quite frankly, what people want isn't what's best for them. The bottom line on it is, if you look back to where our care has been most effective, it's been perhaps delivered by a group model where people who have the expertise to be able to decide what treatment methods work the best are much better off than someone who says, well, I know I've got this disease. I'm going to go to the Mayo Clinic and 3 other cancer institutes to try to find out where somebody's going to tell me what I want to hear. It's quite frankly, the freedom of choice has been a real problem for us. The idea that everybody, that consumerism and the consumer-driven healthcare system is something that can work is another fallacy. People don't understand the systems well enough, nor do they even understand the basic medicine or the basic biology to know what to ask for. So we have a grave educational lack in this country as to how the systems can work, what would be best for us in the long run. And the difficulty right now is that there's a political will to get something done. And, you know, that's a great idea. We finally have an opportunity to get something done. I just wish that we had a better consensus as to what that thing could or should be.
Great. Let me just pose 2 more questions, then I'll open it. We'll leave a full half an hour for you. So, Laurie, in the last week, we've heard, out of nowhere, it seems, Laurie's been following very, very closely, a pretty vigorous debate about reproductive health in the country and coverage of reproductive health within the health reform debate. So it'd be interesting just to hear your perspectives of what happened, where that came from. Maybe it was always percolating and people have just made it public. And then is there a resolution to move that forward so it doesn't derail other health reform issues, or kind of fill us in on that?
So I always sort of bristle when people say, is this going to derail health reform? Because so first of all, we're not a special interest group. Women are half of the population. We're
just a large special interest. That's
yeah, exactly. We're the biggest purchasers of health care. We're the largest users of health care. We're mainly the decision makers, and we're the largest number of providers of health care. So women out there, and everybody tells you that you're a special interest group, just remember that. We also spend 68% more in out-of-pocket costs than men, largely because we're the ones that reproduce. So there's been a really interesting subplot going on here about whether or not we're going to cover our reproductive health care needs, and which this always happens. So I had the benefit of, I have really strange perches that I've been on for healthcare reform. So the first go-around in '93, I was working for the late Senator John Chafee, who had the leading Republican plan. And then about 15 years later, I was with now Secretary of State Hillary Clinton, but then Senator Hillary Clinton, and I helped craft her presidential plan for healthcare reform, which, of course, didn't work out so well. But what I can tell you is that as we were crafting that, we were thinking about the really important lessons that we learned from '93. And the biggest lesson I think we took away from '93 was don't take things away from people that they already have. So women right now who purchase health care in the private market, roughly 50 to 80% of health insurance plans cover the full spectrum of reproductive health care, including abortion care. So the argument is when you create a new health insurance exchange that's going to have both people who are paying full freight and also people who are going to be subsidized to some degree and more generously depending on what their income is, should that plan offer abortion coverage? I would argue that it should, because why should you take a benefit away from people who right now, if they went out to buy it, roughly 50 to 80% of them would get that coverage. And it is, of course, the only benefit that anybody is talking about singling out and excluding from coverage. I don't think that there's any conversation about excluding coverage of heart attack coverage or diabetes care or, I don't know, you name it. I haven't heard that. So the allegation is that abortion care is going to be mandated in this plan. I don't know why it would be mandated more than any other benefit. I haven't heard anybody say that any other benefit is going to be mandated because as these plans are being structured, the way that they are going to decide what benefits are going to be covered is they are going to kick it to some independent commission to decide what should be covered, and that independent commission will decide what benefits should be covered, whether they should cover cancer and heart attacks and diabetes coverage and cleft palate and the whole range of benefits, and abortion care and family planning. And we believe that's the way it should be, because we believe that doctors should make those health decisions, not Congress, and not politicians. So there's been a raging debate about whether they should have something that says everything, the commission can decide everything except abortion. Abortion can't be covered. And everything can be paid for except abortion can't be paid for, because there may be some small amount of federal funds that could be used to pay for abortion. We think that's a really bad move, and we think it's fundamentally unfair, and we think it's taking benefits away from women that they currently have. And the best example that I can give you is right now, you could be in a plan like, I don't want to use Blue Cross Blue Shield, let's say Kaiser, and you're getting your coverage, and we go into this new plan, and suddenly your plan, and you have abortion care, and you don't know that, but you have it, and you have coverage for family planning and everything else, and then you're in the new world, you're working for a small employer, let's say, and your small employer then goes through the exchange, and all of a sudden, you don't have coverage anymore. Why? Because Congress has decided that you can't have coverage in the exchange anymore for that particular set of services. That's fundamentally discriminatory. There's been a whole series of polling done on whether or not Americans think this is fundamentally discriminatory, and they think it is, and they think it's a really bad decision to start going down that road of having Congress single out particular benefits that they think shouldn't be covered. So we are obviously opposing that and think it shouldn't go that way. This isn't the only issue for Planned Parenthood. I mean, we are providers to 3 to 4 million low-income women a year. We are abortion providers, but 97% of the services that we provide are preventive and primary care for women. We are the entry point for primary and preventive care for all of those women without whom they wouldn't have primary and preventive care. So it's an unfortunate debate, and the reason I bristle when people say, is it going to bring down health care, is because we're not trying to bring it down. It's the really right wing that keeps saying, the only people who ever want to talk about sex anymore in this country is like the right wing. They just want to talk about it nonstop.
Some of them, I don't think every.
Right, exactly.
Others probably would prefer not to talk about.
South Carolina governors, right. Senators from Nevada.
Right, exactly. We would love to have like a really good constructive conversation about it, but unfortunately this is the only time it ever gets talked about. So that's the subplot. So stay tuned.
So if I could just add something in terms of taking it to the broader policy level, which is the idea of an exchange is really a good one. The question that is yet to be resolved is the exchange going to be a market facilitator to create more user-friendly, instantaneous capability for a person to shop in a single place and look at multiple plans and determine which one is of better value to them? Or is it going to be a government regulatory body that's going to tell Americans what they can and cannot have? That's really the policy debate. I mean, what we just talked about is just another battlefield in the culture war around abortion, but it does, the bigger issue is this exchange going to be a market facilitator, or is it going to be a government regulatory body that's going to tell people what they can and cannot have? And I think that has not been, there are certainly different views. I'll be very interested to see what the Finance Committee comes up with in terms of their take on the exchange. But what we've seen so far is a pretty heavy government regulatory body, which personally I think is a mistake. For reasons that Laurie has just outlined in one area, but there will be many skirmishes around this if the government starts wading into these kinds of personal issues.
I think your point was a good one about what this thing might look like. The exchange is a concept right now. Whether it's a co-op or state-by-state exchange, still all of those issues are still on the table, let alone whether there actually will be one or not. It looks like from the design of the bills that have been coming forward that there will be some kind of a mechanism along that line. But what the ultimate structure looks like is a big question mark.
I admire my colleagues a lot. I think we have most progressive insurers I've dealt with at this meeting. I want to take issue with Mark and ask for a little comeback, if you would. Government's us. I happen to have a genetic issue in my family that I need my kids screened for. My insurance company won't cover it, and it's a desperately important issue. I have no recourse. I just speak to some clerk on the phone, and they tell me what's covered and what's not. There's no accountability there whatsoever. Government can be accountable. And if we set up governmentally sponsored interventions in the exchange, possibly a public program, we stand a chance as a country as having financing of healthcare be accountable to the public, which it isn't today. Private insurance companies are not accountable to the people covered. At least I don't understand it.
Let's have a talk about that. I feel very accountable for the decisions that are made in my shop, and have times been on the phone personally as CEO of the company with individuals apologizing when we've made mistakes. I feel extremely accountable, and when we lose an individual from who fires us, or lose a group who fires us, I feel extremely accountable for that. And frankly, I think that, my experience has been that private industry, and I'll take it out of healthcare, tends to be much more accountable and fleet of foot in responding to changes in society and needs than the federal government has ever been. But I think you raise a good question, because I think a lot of people have experiences like yours. And one of the things that I personally believe is, I'm speaking now for myself. I personally don't particularly like an employer-sponsored structure for healthcare in this country. I think it's an accident of history. Mm-hmm. I think it leads to a lot of distorted kinds of things where an employer makes a decision about what they're going to pay for and what they're going to get covered. They then go to the insurance company and say, this is what you can and cannot pay for. And then when an individual like you wants to get, needs something covered, the plan's in a bind, because they've made a contract with an employer that says this is what you can and you cannot pay for. And I've personally been in arguments at times with employers saying, but this is an exception that needs to happen. There's a reason for this. And the employer says, not with my money. And so you have this sense of opacity that occurs and disconnection from the needs of an individual. And then that individual is somewhat trapped, because it's not like they can easily fire. They can't fire their employer very easily unless they want to be unemployed. So they are stuck with decisions that are made that they don't have the ability to move to a different company that would cover it, for example, and have a different sense of values around particular decisions. That's a problem. I don't think I don't think that's a value add. What is value add in the current system is that employers provide a significant private subsidy to help people be covered. But I think there's a different way of doing that. And if you look at the example of the Healthy Americans Act by Senator Ron Wyden, one of the things that is the cardinal feature of his act is sweeping away the employer-based system. He and I have had a number of arguments about that because he wants to do it very quickly, and I think it needs to be done over time. But having that as a long-term goal is a good thing because I think it will create a more responsive system that is more accountable at an individual level as opposed to accountability at an employer level. And I'd like to see that happen over time.
So let me, I'm going to turn it over to the audience.
That's something I'd like to debate, but go ahead.
We can keep that one going, but let me turn it to the audience. If you make me a promise, you're going to ask 2 questions. Someone's going to ask a question about financing, because I was going to ask that to them, because I actually think that's a pretty poignant question, given there were a lot of concerns around we're not quite there yet. Maybe we're 60, 50, 80% of the way there. How are we going to pay for it? And then as long as someone promises to ask a question about prevention and wellness, since we can hear more about the Aspen stewardship. So if I get those 2 promises, we'll open it up to questions. All right? Good. How about right here in the front?
So I have an interesting question, which we're kind of talking about. And in the perspective for the healthcare reform debate, we'll come up with some solution about how we want to do it. But then the issue comes up, and I'm going to go back to Dr. Berg's point, in systems. And Dr. Alonde wrote an article about this, which didn't get as much traction as the one that we're currently talking about back in October, where he talked about the development of systems and single pairing and how we got to the American healthcare system currently. And my question is, when we figure out what we need to do, there will become a point where we need to make a transition. And then there's 2 ways we go about it. We can do transition quickly, or we can do a transition abruptly, or we can do a transition gradually. But there's a lot of issues with both parts. And I wanted to know from the panel what way you think transition can happen that will best help the patients, because there's a lot of issues that come with both sides.
Who wants to take it first?
Can I just ask a question of the questioner? Transition to what end?
Exactly. So transition to what system? So we will come up with some system that we think is best practices. Do we want to make the change on a national scale quickly, or do we want to make the change on a national scale gradually, and why?
So, one thing I would just, before I defer to all the experts here, is that I do think that healthcare reform is always happening. So it's not like while we're all here having this conversation and over the past couple of years that it hasn't been happening. I think you see it in the states all the time. So you see what's happened in Massachusetts. And I can even speak just from the perspective of our health centers, our 887 providers, that the delivery system for them has changed very much in the 90 years that they started as individual health centers, and the way that they have now are looking at sort of the much more integrated model and having to think much more about how they go from being sort of individual family planning centers to moving into a more integrated model. So I think even if you look at some of the changes in the debate from 1993 to now, some of the flashpoints that worked then, like the scare tactics, you're not going to have choice of doctor or plan. Well, most people now don't have a choice of plan, so that doesn't work. So I think you're seeing a lot of transition all the time, and a lot of changes in health reform. Health reform is sort of happening all the time. So, but I'll defer to you all as to sort of what the best way to go is.
Do you want to? How about let's suppose it's good. Let's suppose it's the good big, as John said. Good big idea.
I don't know. I got two thoughts I have in response to your question. One is, I think there's a subtlety to what we could do legislatively that I think is important, which is let the fastest communities go as fast as they want. If we come up with reductionist legislation which plays to the middle and don't have hatches through which very progressive communities and economies can move really fast to integrated care, new relationships between physicians and hospitals, focus on prevention, we'll be slowing down people that could show us the way. On a larger scale, I don't have any wisdom on this. I think the time has come to do something big, fast. I think that if we change the game now, the adjustments will follow. We saw it in Massachusetts. Massachusetts passed a law for universal coverage before we knew how to do it. We know it's hard. We're working our way, but we had 98% coverage in Massachusetts now. I don't know if you saw David Blumenthal's article in the New England Journal of Medicine a few months ago, where he had the tapes of LBJ meeting with the Medicare and Medicaid legislators. This great paragraph in which someone comes into his office and says, suddenly Medicaid was thrown in. They had Medicare, and then someone said, oh, let's add Medicaid. And it was enormously expensive. And someone came to LBJ's office and said, this is going to be really expensive. What should we do? And he said, go get my brother. And Go Get My Brother was a story he told about this guy who was watching, was it a train track? And there was one train coming from one direction, one from the other, and they were about to hit each other. And someone said, what do we do? And the guy said, go get my brother. He said, does he know anything about trains? No, but he's never seen a train wreck. It's a form of courage. And I think it's time to disrupt.
There's the humor from the session before. So let's go here on against the wall.
I actually have a question for the audience to start with. I'm just wondering who paid. I'm self-employed and I buy my own insurance. And this idea that you can be an informed consumer and go out there and buy a plan, I mean, it's a joke. It really is. Not only that, I'm insured now. I have been for a long time. When I was younger, I wasn't insured, and I would go in and the idea that I could negotiate with my doctor, that's another myth. They actually would try and charge me more, even though I was saving them paperwork. So I'm just curious if anyone else in the audience who's gone through this experience.
How about your children, for those of you who haven't raised their hands? When mine were in their early 20s and out of school, that was a problem of trying to convince them they really weren't 10 feet tall and bulletproof.
So then my question is, why aren't we talking about a single-payer system, and why also, how do we get it decoupled from employment? You would think that the business community could really get behind that and help their competitiveness.
Randy, Mark?
Well,
Yeah.
yes and no. If you had an option,
They're going to pay for it one way.
Yeah,
businesses are going to pay for it one way or the other. They're going to either pay it through taxes, they're going to pay it through direct premium. So it's the idea that it's going to be cheaper because it's government run is I don't think history has borne out that is to be true. On the other hand, to your question, I think the issue of whether or not we go with single payer is being debated. It's certainly in my area of the country debated pretty furiously in terms of whether or not that's the right way to go. And my view is if that's what Americans want, and the polls don't suggest that that's what they do, but if they do, then we should get on with it. I said that yesterday in a panel. I think that should be a decision that we make, and then if we do, we move. What I do have a problem with is doing it on the installment plan, where we don't say that that's what we're trying to do, but we're going to do some things that are going to basically guarantee that happens over time. And that, I think, is wasteful. And I would rather us be honest with ourselves and say, this is what we want, or we don't want it, and then move forward from there.
Congressman Conyers has been behind a bill, H.R. 676, a single-payer system, for a number of years. He put it out there. And there are a lot of groups, particularly unions, that have supported the idea of single-payer. But if you look back to the debate that took place while each party had 15 people running for president, there wasn't really anyone in a viable position to make that run who was advocating a single-payer approach. It was viewed as being too far to the left, too extreme, and it was hard to get any support for that. The system, if you look at healthcare, you have to pay for expenses. You have to, for the coverage, what it's going to cost you to provide the care, and you have to pay for some kind of administration on it. Medicare is a system to do that, but Medicare is by and large run through third-party intermediaries. They have intermediaries paying the bills. It's not like you have all the bills going into Washington. It is a single-payer system by virtue of them creating what the benefit structure is and how they pay for it. It's not an unreasonable approach, and I think that the employers that sponsor the plans that I'm in wouldn't find that to be an unreasonable way to go either if it was a clean move. What my stakeholders, and coming back to the topic here today, what my stakeholders object to is having to pick up the tab for all the other people who don't provide coverage and have to shift those costs to them and putting them in a non-competitive position. The higher and higher the costs go, and it depends, it doesn't really matter whether it's pension or health benefits, The higher the costs go to provide any kind of social benefits for employees, the more non-competitive you become with an employer who only wants to pay the least amount of wage. And so it's much more efficient to do it through a government system.
Yeah.
Got a few more hands up with that, didn't we?
Thanks a lot. I've been working in this area and doing a lot of practical work across a number of countries, UK, Australia, Canada, US. I built a US healthcare company a number of years ago. I worked very closely with some very good clinicians who have actually been working on the issues that we talk about for about 30 years. And have more data, by the way, than anybody in the world on this stuff. First question I'm going to ask you, which we never really address in this country, in other countries we can, is again, what is the purpose of healthcare? Now, we talk an awful lot about consumer healthcare, and we talk about, how do I price this or that? What am I buying? People don't want to change their doctor. Well, what are people after? They're after wellness, and they're after the maintenance, to the extent possible, of their lifestyle. So whatever we do has to be selling them, in effect, wellness and the ability to maintain your lifestyle. It may be through your current doctor, it may be through some other system. But the key is to understand what is the fundamental problem in healthcare. The U.S. is a mess. It's shit. Okay? The UK is much better. It is. You look at the figures. I used to work for the Congressional Budget Office, by the way. I used to generate the numbers that you talk about. But you look at the UK, much better in terms of cost growth. But the fact of the matter is every single industrial country is in trouble. We just get there first. Okay? And the biggest problem for us, of course, is chronic disease, which is very different than acute illness. Very complex over the lifetime of a patient, over the geographic spread of the patient. Wherever the patient is, that disease is different. We have to manage that. So if you look at that, the problem in healthcare is actually quite simple, but it's not recognized, unless you're a clinician, I suppose. First of all, we're not as smart as we think we are. Okay? In a proverbial sense, you only know 5 or 10% of the clinical knowledge that's available. We can go to the library and get all sorts of studies, but what the studies tell you don't tell you what's happening with my patients. And there are all sorts of problems, fundamental problems with controlled studies as applied in daily practice. Okay? So we're not as smart as we think we are. The second problem is each and every person is different. So if I develop standardized protocols and I apply them equally, I'm going to undertreat half my patients and overtreat the other half, and my costs are going to go up. Okay? And that's a fundamental problem. The other thing is we have to start thinking about healthcare and talking about it as a risk management business, because that's what it is. What you're trying to do is deal with the uncertainty of the future, whether it's clinical uncertainty or financial uncertainty. Secondly, we have to talk about how do we align the process of financial clinical risk management, or financial risk management, and clinical risk management. So, if we talk about a single payer, we have to be very careful. We have a single payer called Medicare, which then farms that out to other folks, and you can change plans. One of the greatest problems in this country is people can change plans too often. Humana tells me that 20% of their membership turns over a year. They have no vested interest in your long-term well-being, and they'll admit that. In fact, the disease management programs I've encountered, I was involved in that in the 1990s, all tend to, whether it's in pharma or on the payer side, all tend to come out of the marketing budgets. These are not proper P&L businesses. Okay? But
so what's the take-home message, or what's the question for?
No, it's not going to be a question. Okay, this is the Aspen Forum.
Sure.
So we can have a discussion, and I'm sure there will be some comments. But the other critical piece in all of this, absolutely critical, is we don't have any data. And the focus on an electronic medical record is important, but the reality is where the focus is today is moving us backward, not forward. And I won't discuss the detail. But I will give you an example of what is possible, because we have, as I mentioned, more data than anybody in the world. We just finished a 10-year study at Cornell. And over the course of 10 years, most of the results occurring in the first 2 years, looking at patients, complex patients, these are ESRD patients, so they're dialysis patients, lots of comorbidities. Across, so managing care from inpatient all the way to the home, completely the mortality rate within 2 years fell up 49%. In fact, because it's a multi-center study, the mortality rate across 3 centers was 35 to 46% below nationally. The hospitalization rate fell 40%. Now that's really interesting because in our system, the way we do it, there's no economic value there. In fact, nobody could care less about reducing hospitalizations. In fact, the hospital wants you to be hospitalized. But the punchline is, and this goes back to the whole issue, can we have better quality care at lower cost? The reality is quality care is lower cost. So in this particular instance, they get far better outcomes, but in fact, they are able to treat something in the order of 40% more patients per clinical staff member than the national average, and they automate the whole billing process. But the key is a particular form of data management: 1, continuous feedback, and 2, transparency.
Thanks. I'd like to allow others, and thank you very much. Don, do you want to take a response to that? I think it's in some sense agrees a lot with others who want out in the back here.
So a lot of the debate for healthcare reform has been providing coverage for the uninsured, which we all believe is morally correct. But really, don't we need to change the system and the way healthcare is built? Right now, we focus on a procedure-based kind of system. Shouldn't we force the creation of health providers being in networks and no longer paying per procedure, but paying upfront on a salary basis, and not have that? And shouldn't we also at the same time try to reduce the need for excess testing that is only trying to CYA to prevent malpractice insurances by changing the way the system works? Don't we have to address the system instead of just the pay?
Very much so. I think if you, again, I would refer you back to this because this book talks about the broader issues involved. I come from the great state of Oregon. That's where our home base is. And some of you may remember that we had our 15 minutes of fame on the healthcare front a few years ago with the creation of the Oregon Health Plan. And at the time it was considered very progressive. Certainly for a Medicaid plan, it was very progressive in the way that it approached trying to bring more people into the tent. The problem was it was only about bringing more people into the tent. And the trade-off was we'll do it by creating a list and essentially a rations approach. Our company, because we believed that the Medicare system was broken at the time, Medicaid system was broken at the time, jumped in with both feet to try to help support and make that happen. But none of the systemic issues were changed in terms of the behaviors of the delivery systems and the way they were paid. It was still primarily, intervention-based payment. And the plan quickly became insolvent. It was like Massachusetts in the early years. The Oregon Health Plan did bring a lot of people in, and so we were patting ourselves on the back for the fact that we had created a lot more access. But it caught up to us pretty quickly. And when the bill came due and there was no one to pay it, Regents ended up paying about $39 million over 2 years to privately, in a sense, subsidize it. And when we, as a not-for-profit, could no longer afford that, the system collapsed. And we ended up with fewer people insured than before we started. And that's something that I worry will play out in Massachusetts because they've done a similar thing even on a much grander scale in terms of coverage. My hope is that what came out last week in this notion of a global payment approach, which starts getting at your question, if that will take root and the special interests there are some vested interests that don't want to go there, but if they can see beyond their own self-interest and move in that direction, then Massachusetts has a chance. But it should be noted that Massachusetts is already over budget from what they projected. And if they don't do something, they're going to go the way of Oregon. So take that to the national debate. I worry about us using those kinds of models and only making it an access bill. It's got to include the broader piece if it's going to be economically sustainable and really create social justice.
Let me hear from Randy and then Don, and then I'd like the panelists to finish what I'd actually, since it is the prospects for President Obama's health reform plan, if anyone here on the panel would like to take a shot at what they think the prospects They're much closer to it than we are. So if we'll hear these and then...
Yeah, I'd just like to follow up on that. You're right. You've got to change the way the system is structured. And under the heading of there are no new ideas, if you look back at probably the largest of the kinds of trust funds that I worked with is the Mine Workers Health and Retirement Funds. It was created in 1947, and it really brought health care to Appalachia. Talk about the medically underserved. That entire area was medically underserved. This trust fund built a string of hospitals. They built ambulatory care clinics, and they brought in physicians. They deficit funded it, and within the coal fields, they paid a per diem rate to all of the hospitals that were on the participation list. It was a closed panel system. We vetted all the physicians. We paid many physicians on a retainer basis. At the time, we'd started out with, because it was cradle-to-grave coverage, there were no copays, no deductibles. But we could go in and say to the hospital CFO, you have no bad debt from any of our people. So we're going to take your budget and we'll divide it by the number of bed days we'll represent, and we'll give you that per diem amount. It started to break down when Blue Cross came in and started doing retrospective rate adjustment and saying it didn't matter what you spent, we'll come back and pay the difference at the end of the year. I had one hospital I was saving $600,000 a year. This is back in the 70s. I was in one facility I was saving $600,000 just because we had an alternative delivery system. We didn't care about the procedures they were ordering. The physicians were being paid on as a block of time. The others were in the ambulatory care centers were on salary. But in the late 70s, the participants in this fund said, wait a minute, I'm being treated as a welfare patient. I don't have the choice to go to the doctor that I want to. And within a year or so, there was a change. There was no longer a participation list. It was simply freedom of choice. The budgets blew out completely. That system broke down. The active coal mining population went on an a company-by-company insurance model. And at the end of the first 2 years of that experience, everybody wanted to get back into it because the costs were just blown out of control. So there are alternatives that can work. They work better in a non-profit hospital environment. We don't have that any longer. The for-profits have taken over so much of the hospital care in this country. It's no longer the Sisters of Mercy running things. So, yeah, there are ways of doing things. It's a different environment we have now, but clearly, as long as we continue to encourage overutilization by paying fee-for-service medicine, the system's going to continue to have major problems.
So to close, before I thank the panel, because I think this is the prospects for health reform, and we've got a bunch of people who are pretty close to it. If anyone would be willing to share what they think the prospects are as we sit here on July 26th. Start with John and go down the...
I think the prospects are good but not great. But the best chance that we've had, the best bite at the apple we've had, as I said earlier, in 5 decades. And relative to how fast, I agree with Don, we need the kind of disruption and in the fast move to this. When they talk about the control of costs, that's one thing that everybody seems to agree with, that the current thing is unsustainable. But there's another point there. And by the way, I think there's ample evidence that we can afford much better health care and get better outcomes, and that we can stipulate that. But another key point about the economic viability and the competitiveness of this nation has to do with we have to keep people healthier longer. So when you have type 2 diabetes in children, which used to be referred to when I was in graduate school as age-onset diabetes, who are then going to go blind or have their amputations, 2 decades or 3 decades sooner, you're talking about a future of America that could be the healthiest nation in the world. Could be. But we won't even be competitive if we end up with a disabled population. So the widest range of health is not in neonates and not in adolescents and not in the middle age, it's in the old. And half are viable and volunteering at the museum and the other half are vegetables. So we have to find a way to provide health care that truly does promote health, sustain health, and prevent disease. And this is the best chance that we have to, I think, have a major a shift in that. And hopefully we'll get it. Sorry, didn't mean to talk that long.
Any others want to offer their prospects?
I know exactly what's going to happen, but but I'm not at liberty to share that.
It's on your website, right?
I want to add a note of optimism. I really think in these bills there's a lot of good stuff in them. The staffs are thrilling to deal with. These are very, very smart people struggling really hard in a tough climate. I like the parts of the help bill are focused on quality. Title II of the help bill is revolutionary and terrific, and that's the bill that's not getting attention right now, but it's very good. There's investments in measurement that I think are going to be helpful. There is move toward better coverage. So I think we're going to see something that'll begin to change the game. I hope it's bold. We'll see.
I think it'll happen. I think it'll be more incremental than universal, but I think it'll happen. And I just think partly because the cost of not doing it is so overwhelming that we can't afford not to. And I think the president and some of the leaders in Congress have put too much on the line for it not to happen.
Yeah, I think there will be something that passes by the end of the year. But that's the big question. What is it? And a lot of people are leery of buying a pig in a poke and deferring too much to a national health commission of some sort. So those are the big question marks that are out there. But from a political standpoint, the stars are lining up pretty well.
I had the privilege of speaking last summer here at Aspen at the Ideas Festival, and somebody asked a similar question, and I said, this was before we knew who the president was going to be, and I said that whether health care reform will happen will depend on whether the president makes it the central issue of his presidency. And if, because of the forces, both large and small, that want their thing in the bill, it's going to take real presidential leadership to drive what will happen. And I have great hope, because I think we have a president who has staked his presidency on it and is making it a central focus. And that's what it's going to take for it to happen. So I remain optimistic. I think this is the window. This is the opportunity. Yeah. And if the president can stand up to his own party, frankly, because I think he's got to, and drive what is a bill that can pass, and then I think it will happen.
I'd like to end by thanking the panelists for two things. One is for some very thoughtful remarks today, but two, probably more importantly, as you heard, they all are part of the solution. And they really are trying to make these bills, as they're working through Congress, better at every single level so that we actually get a big, good idea, as John would say. So I want to thank them for their work and for their thoughts today.